morning, ladies and gentlemen. Thank you both to Lauren and to Rob for a very excellent opening to this series and for a very, very kind introduction. And as I look around the room this morning, I see the faces of many people who have continued to advise and support me, including long before I had the privilege of serving as Minister of Health in Alberta. And I hope all of you know that this is very much a team effort. Our accomplishments, and there are many to talk about, are a result of collaboration, but the challenges that we're currently facing are also going to be met as a result of that commitment and collaboration and your willingness to provide me with the very sound advice and tremendous insight that you do. Thank you to Rob and Lauren. As I said, I'm joined by several colleagues this morning, and I think one that we may not have mentioned yet is David Dorward, who is here, who's the MLA for Edmonton Gold Bar. So on behalf of my colleagues and of course the Premier, it's our privilege to be here, and my privilege this morning to join you as the first speaker in this series. I'm not noted for making scripted remarks, and can be a good thing or a bad thing in my line of work. But I am going to read a speech that I prepared for this morning, because there are a number of things in here that I think are important that I really want to take an opportunity to convey, and I'll do my best to leave some time for questions. When I started to think about today, I asked myself probably the most obvious question. Given all the speeches that have been made over the last decade and the sort of state of the nation speeches about healthcare in the province and what directions our system needs to take, what would make this one particular set of remarks this morning any different? And of course, we have many accomplishments to celebrate, as I said, but also many challenges in our health system as we see across the country. But the thing that has struck me as a result not only of this experience as minister, but almost 30 years now working in the field of health policy, is that there are certain challenges, certain issues that seem to never change. In fact, I was provided a note from a friend recently, and I thought it was quite interesting. It contained a resolution from a meeting of the Alberta Hospital Association at their convention that was held in the late summer of 1919. And the resolution read as follows, quote, "To impress collectively on the authorities of the province the great need for increased accommodation and services for the aged, the tuberculous, and those suffering from chronic conditions who are at present occupying bed space in our active treatment hospitals," unquote. And the tagline at the end of this email was, "Could someone please get on this as soon as possible?" So it's interesting, and I think, of course, and I'm sure you would agree, the time has come. We need to move from a system that is focused primarily on acute care and rescuing people who experience, in many ways, failures of the system, in other words, acute episodes, preventable acute episodes, to a system that truly supports independence and early intervention for lifelong health. And I think now there's a readiness for change that has not existed before, both in Alberta and across the country, and that readiness is driven by a number of things. First of all, there are some very serious fiscal imperatives driving change, to be sure. These fiscal constraints will only increase as we move into the future. Recent reductions in provincial revenue, for example, has served as a wake-up call to examine what the real problem is, or at least one of the real problems facing our system, and that, of course, is an unsustainable spending curve. Secondly, we have new knowledge and we have new technologies, and we've organized ourselves to take advantage of those that can assist us in moving from a hospital-based health system to one that is more centered in primary and community-based care, and I'm going to talk about that more in a moment. And thirdly, we must finally face the reality about how the health system is performing compared to others in the world. And so while we have taken great pride in stating that we have the best health system in the world in Canada, and especially in Alberta, we need to face an inconvenient truth. And the fact is that we do not have the best healthcare system in the world, and depending on which performance measures you look at, we don't necessarily always have the best healthcare system in Canada. But I believe that we can. We can have the best healthcare system in the country and in the world. And of course, this is not to say that there is not already outstanding care provided in Alberta. We have a system populated by great leaders, many of whom are in this room, and we have outstanding providers and caregivers. But we have been trapped in an old way of thinking, in a way of thinking that has trapped many of us involved in health system reforms, and I include myself in that. And you've heard about some of my previous experience. And so the problem is this. Our thinking has looked at the health system from a perspective of three components: access, quality, and cost. And I believe the belief to date has been that you can only improve two of these three things at a time. If you improve access and quality, you can't control cost, for example. Or if you control cost and improve quality, you'll have to reduce access accordingly. Well, I think that paradigm is being very seriously challenged by thinking that we can point to around the world. We can, in fact, improve on all three. And the answer is something that many, I think you will be familiar with, and it's a conceptual framework developed by the Institute for Healthcare and Care Improvement called Triple Aim. And so the three things are better care, better outcomes, and better value. So the question is, why think about this now? And how do we use this framework to focus our efforts in the future? Well, the answer is that Alberta is different. Our health system today is different, and our readiness, most importantly, to take the next necessary steps in the evolution of healthcare has progressed considerably. So, a few points in this regard. First, our province is changing rapidly. Our population is growing. Our baby boomers are over 60 years of age now, and they are living longer. More and more Albertans are living with chronic diseases. From 2002 to 2012, our population grew by almost 750,000 people, double the rate in the rest of Canada, and we expect that growth to continue over the next decade. By 2031, 1 in 5 Albertans will be a senior. The number of people receiving publicly funded continuing care services is expected to double in the next 20 years, from about 57,000 to 110,000. And in any given year, about 5% of Albertans, and this is recent data, which I think bears repeating, about 5% of Albertans, those with multiple chronic diseases, mental illness, and other complex needs, drive about 60% of spending in our healthcare system. So these realities put some very obvious and significant pressures on the system, and I probably don't need to spend a lot of time on these. But I think we need to probe a bit further. What else is different? Well, first of all, I think people's view of healthcare has changed considerably. Healthcare is becoming personalized. And by personalized, I'm not talking about genome mapping. I'm talking about making sure that care is tailored and organized around the needs of individuals, as opposed to the needs of governments and institutions and providers. And making sure the system is tailored and organized around the needs of different populations in our society. So this includes supporting people taking a stronger role in self-care and in self-determination with respect to their own health. Albertans see an increasing responsibility for their own health, and I hear this everywhere I go. They want more of a direct say in the treatment options that are available to them. They want to be full participants in decision-making about their health care, the care of their children, and in many cases, the care of their aging parents. They want the health system to operate more like other aspects of their lives in terms of convenience. They want electronic communication with providers when that is convenient. They want access to care outside of regular working hours. And given this, health leaders need to shift their policy and planning questions from what does the system want to what do people actually need. And I would be the first to acknowledge that there is often a difference that those of us in healthcare perceive between the wants and needs of individuals. But I think the needs that people are expressing are in many ways connected to that desire to take more responsibility for their own health, to be participants in decision making, and to have the tools and support to do that. And for some economic reasons I'll mention in a minute, we, I believe, have a very strong interest in leaders in supporting our citizens in that desire. Another difference today is that Alberta has a single platform for change. We've consolidated, as you know, 9 standalone regions into a single integrated health system. Many other jurisdictions look at this consolidation with interest, some of them with envy, because of the opportunity it presents to align our services more effectively. It also allows us to conduct research and clinical trials across populations more efficiently and to measure results across the system. And the partners that are sponsoring this breakfast this morning are very much engaged in integrating research with the delivery system. It's a tremendous opportunity that's unparalleled in the rest of the country. With a single system, we're no longer competing for projects and dollars across regions. Instead, we're making tremendous strides in integrating best clinical practice, knowledge, and efficiencies across the system. And many of you will know that to date we have found over $700 million in administrative efficiencies across the health system, but there are many more improvements still to make. Too often, people have difficulty finding the care and supports they require. Transitions between primary health care, specialist services, hospital care, and social supports are not as seamless as they can be or as they should be. and we are still very much providing services and care in hospitals that can be better provided and accessed in the community. We have a single province-wide platform that provides many advantages, but we cannot overlook the importance of ensuring that we never lose touch with local issues and priorities. We must never assume that one size fits all. So I want to take a few minutes now and talk about health outcomes in our system. I can say, obviously, that our system has the finest hospitals and technology in Canada. Many of the people in this room have participated in initiatives over the years that have resulted in strategic investments, more recently in the form of projects like the South Health Campus in Calgary or the K Edmonton Clinic. The first electronic health record in the country was brought to fruition in Alberta. We have all of the bricks and the mortar and the medical technologies, and many provinces, I can tell you, envy us in that regard as well. But despite all of this investment, and despite, as was mentioned, a budget of over $17 billion, about 20% above the average in the country, I cannot stand here as your minister and tell you that Alberta is delivering the best health outcomes. Albertans' life expectancy at birth ranks 4th in the country. In 2008, infant mortality in this province was the 3rd worst in Canada. And in many instances, people are not being cared for in the right setting, resulting in increased waits for needed services. For example, we are higher than the rest of the country in the CIHI report that came out earlier this week with respect to rates of hospitalization for diabetes and hypertension. And these are things that CIHI classifies as ambulatory sensitive conditions. In other words, these are examples of what happens when we fail to effectively manage chronic disease and increasingly comorbidity in community settings where they can be managed and can be managed better. These are conditions which should not require hospitalization. Another example of some of the poor outcomes we're experiencing is with respect to continuing care patients who are being held in acute care beds. And we've made some progress in reducing those numbers and reducing the waiting time, but nevertheless it is still an issue. It backs up admissions in emergency departments and keeps our seniors from receiving the right services in the right place to fit their needs. And when we look to measures around patient satisfaction, we can see that there is significant room for improvement. In the HQCA's recent survey, only 51% of Albertans rated access to healthcare services as easy, and 13% who received healthcare in 2012 had a serious complaint about their experience in our healthcare system. And those statistics are clearly not good enough. So in my view, we have a responsibility as a government, as providers and leaders in healthcare, and as a society to answer 2 questions. Why aren't we doing better, and what must we do to improve these results? Well, one thing we know for sure is that better healthcare and outcomes will not come by simply putting more money into the healthcare system. Greater per capita spending does not equate to greater value, and we are a case in point in Alberta in that regard, and we have been for decades. If it was the case that more spending produced better outcomes, Alberta would be leading the country with respect to all the things I just mentioned and in other areas as well. In fact, our health cost picture shows a steep, continuous climb in costs. We've heard about the last budget, so we're at just over $17 billion in the province. Our per capita annual spending is 20% more than the national average. Health and wellness spending 10 years ago was $7.4 billion, or 35% of government spending. Today, healthcare has climbed to 45% of overall government spending. And I can go on, and I'm sure many of you are familiar with these numbers. But I think it bears repeating that our province is spending $1.9 million every hour, 24/7, on Alberta's healthcare system. And if you look at our neighbor to the west as a comparator, in 2011-12, we literally spent more than British Columbia to serve a population that is close to 1 million people, yet less than British Columbia, and a much younger population at that. So I think we would all agree that the level of spending in healthcare is not sustainable. And in the context of our system today, I think it's important to have a bit of a discussion about what we mean by sustainability. I've come across a couple of definitions for this. The first one, and it's probably the one that I more commonly encounter when I talk to people, is sustainability defined as perseverance through resistance to change. And we've certainly had a lot of change in Alberta over the years. We're fortunate to have been able to afford the ability to rethink our system. I think to make some very significant improvements as a result of rethinking the system, but also to avoid dealing with some other inconvenient truths that I'll talk about later. So maybe our idea about sustainability needs to change. And another definition that I think perhaps we should aspire to is sustainability defined as perseverance through adaptation and change. And so in my view, and in the view of our government, sustainability is not about one-time cost constraint or spending reductions. And I would really want to caution everyone when looking at our experience in the recent budget and the reduction in funding, to look at the changes that we're making in healthcare not as reaction to lower budget revenues, but as in fact a catalyst to do some things that many of us, including myself, have been talking about for many years that need to be done to improve the effectiveness and the efficiency of our system. So sustainability is not an event. It is an ongoing process of assessment and learning, and then honing our processes, budgets, and practices in order to achieve better health outcomes. And it requires perseverance. We simply must get the rate of spending growth under control and get behind the cost curve. But as I said, we do that, I think, by recognizing a couple of things. First of all, and I can point to my own experience, when I started my first job as a health planner 30 years ago, everyone that I looked up to was searching for, what they called the magic bullet that would fix healthcare. Many of us would go off to conferences, young people like myself at the time, simply, believing that there was simply one lever in all of Canada that we could use that would improve the outcomes of our system, the financial sustainability, and all of the other issues. And of course, we know today that isn't the case. But I think we've conditioned the people that work in our system through things like restructuring, through things like rethinking the health system every time a government changes. We've conditioned people to think that there is a magic bullet somewhere, and that we are failing as leaders because we're not finding that and taking advantage of it. And so my thinking, and I think the thinking of many people over the last 20 years, has evolved. The answer is not in a magic bullet. The answer is in incremental improvement. The answer is in using evidence and continuing research to support smaller improvements in our system. The answer is in setting up things like strategic clinical networks that we find in Alberta Health Services today that are defining evidence-based clinical protocols for some of the most serious health conditions that our citizens have faced. And also to help us deal with the increasing demand for some elective procedures. So the fact is, in my view, and it will continue to be my view, we have more than enough resources to deliver much better health outcomes than we currently do in the province. Our challenge is putting those dollars to the best, most effective use. Now, I said before that we're not alone in facing this challenge, and we're at about 45% of provincial spending on health. Ontario and Quebec are getting dangerously close to 50%. And I think that's something that bears a bit of reflection. The number is startling in and of itself. It's a large amount of money for a relatively small population. But what happens when one province in Canada reaches that 50% mark? That is the day that healthcare in this country becomes an opportunity cost for other areas in public policy that are very significant priorities to Canadians. Think about advanced education, for example. Think about K-12. Think about the environment. Think about all of those other public goods that we value as a society that would be impacted. And think about how healthcare would be impacted the day that a province needs to make a decision about how to spend that 50% plus $1. I can assure you it would be a much different discussion than what we have today, and it would be a much more difficult process. So the last part of this, and then I do want to leave some time for questions and to hear your comments, is of course the question everyone is asking, how do we get there? Well, we have taken a very strong position as a government that the way that we get there is to make primary health care the cornerstone of our healthcare system. So using it as a guide, what directions would we pursue to ensure the three triple aim outcomes of better care, better outcomes, and better value? Well, first, I think we have to recognize primary health care for what it is. It is care that's provided in the community. It is the portal to the system for most citizens. And it is the way that we connect, as individuals and families and communities with the healthcare providers that serve our community. And Albertans back this up. When we go out and talk to them about issues in the healthcare system. They will, and I've seen this for over a decade now in Alberta. People will rave about the quality of care that they receive in hospital, whether it's surgery or cancer treatment or something else. They will rave about the healthcare professionals that serve them, that care for them so well. And they will inevitably end their story with everything was fine, my only problem was getting in the door. Well, the way to open that door, we believe, is with better use of primary health care. And there are many reasons for this. I think it bears, again, pursuing the patient perspective a little more. People shouldn't have to tell their story multiple times due to the lack of a shared electronic health record, which is an issue in our system. Access to services should be available outside of regular work hours when it is convenient for patients and families. And complex health problems, like that 5% of the population that I talked about earlier, who are using 60% of healthcare resources, need a team of professionals who work with them on an ongoing basis to address their needs. And not just, of course, with respect to illness, but with respect to supporting initiatives around wellness, better nutrition, early childhood development, all of those other things that are peripheral to the healthcare system, the things that we refer to as the social determinants of health, but that had a very, very direct outcome on the performance of our health system overall, and more importantly, the health of our society and future generations. So I believe that the answer in the future is to provide Albertans with a true home in the healthcare system. A home in their community with a team that knows them, their families and communities, and intervenes early to prevent illness, and when illness occurs, assists them in coordinating access to those needed services. Primary care networks and family care clinics in communities across the province will, in future, deliver a broader range of health services, a more standardized set of core services, and connect people to specialists, to social services, and continuing care as needed. And we will take a standards-based approach to the evolution of primary health care in our province, no matter where and how it's delivered. In this year's budget, we've allocated $262 million in additional funding for primary care networks, family care clinics, and addiction and mental health services. So that's our starting point, is better use of primary health care. How do we become more ambitious about it? And that's why we have set a bigger target than simply expanding funding for primary health care. And this is where I believe our healthcare providers will play a greater role. Our goal, our ambition for the system is to provide Albertans with that home, to provide them with a means of formal attachment or enrollment with a primary care delivery team in or near their home community over the next 3 years. So I want to be very clear what I'm talking about here. I'm not talking about a loose association like many of us would describe with our family doctor if we're lucky enough to have one, or with one of the other professionals who is serving us in the system. I'm talking about citizens of Alberta having the opportunity not to just to be a patient, but to be a member, to be part of a local community-based organization that is dedicated to meeting their needs. I'm talking about using primary health care as a platform to address the social determinants of health that I talked about earlier, to reach out to communities, particularly younger Albertans, to position them for better health. And I think it bears repeating that this is the first generation of Canadian children to have a lower life expectancy than the generation that preceded them. And I'm talking about a system where when people need specialized levels of care in hospital or in other venues, that care is coordinated for them from their home base by their primary care team in a way that provides them with the information and support that they need to leave their home in order to receive that specialized care, and to support them when they return home after that care is provided. And we've had many good examples in Alberta of patient navigation initiatives in cancer care, in cardiac care, and in other areas that have demonstrated with very good evidence that this can have a lasting impact, not just in terms of convenience for the patient, but a real and definite influence in the rates of recidivism for hospital admission, in the long-term prospects for people after an interaction with the healthcare system where there's a heart attack or cancer or other means. So that return to our roots of community-based care, I think, is absolutely key. I'm going to just finish up by talking about some of the opportunities that I think are in front of us, remembering again that primary health care, I think, will become increasingly the center of our focus. What are some of the assets that we have in Alberta that we can put to use to support this movement to a more coordinated care experience for our citizens? Well, first of all, as I said earlier, we have the first electronic health record in the country. We are involved in some discussions now about implementing a fully integrated clinical information system for our province and a fully integrated electronic medical record that would allow us to actually move to a one patient, one record system in the province. It would truly allow health professionals to share information, and again, to go back to some of our public opinion research, citizens, and I'm sure you would have experienced this as well, they very much assume that their information is shared appropriately among health professionals. I think the days of preoccupation, well, confidentiality is still important and still an issue. I don't think it's the public that are putting barriers in the way to the appropriate sharing of healthcare information. I think it's us that actually has to catch up to the public in this regard. So we have those opportunities in terms of our information systems. We have, I think, made a good start with myhealth.com, which is our patient information portal. And you'll see in the next year or so the opportunity for Albertans to be able to see more of their own health information online. Again, this is in keeping with giving people who have the capacity and the desire, and there are many, the tools to support being more active in taking responsibility for their own health. But we have some things to do on the provider side as well. Providers in all disciplines are telling me that compensation models need to change in this province. There is an increasing interest in moving away in medicine from a fee-for-service model, and we have an agreement now with the Alberta Medical Association that is going to position us for some of those discussions. When we consider the fact that, that 5%, a lot of those people are people living with complex conditions, a simple 5 to 10 minute interaction with a physician in the midst of an acute episode that is a result of poorly managing those conditions is obviously counterproductive to the kind of system that we want, that allows professionals in a team-based environment to spend that time both directly with the patient and indirectly working together to support those people and reduce those acute episodes. So there's a discussion certainly to be had on compensation. We need to, I think, as well look at the funding system we have for hospitals and long-term care services in the province to make sure that we're making best use of those resources. And I want to take a moment just to highlight for you that I do have some concerns with respect to how continuing care is functioning in the province, and we'll be spending a good part of the next year focusing on a review of that system. I think it's one that it does a good job of serving government and administrators, but it's a very difficult system for people to navigate. There are multiple levels of care. I think there are up to 9 at the moment. We're not talking a lot about a home care, perhaps as much as we would like. And beyond that, we're not talking about supporting people in self-care, which I think is going to be much the way of the future, nor are we talking about a great deal about end-of-life care, which is the other end of the spectrum. So we'll be pursuing that. As you may know, we're developing a pharmacare program for Albertans. We have currently 18 independent drug benefit programs in a province of 3.8 million. I'm not proud of that. And we have 5 health benefits programs beyond that that deal with things like assistive devices. And they all have different criteria. And so the consequence is that our citizens don't get access necessarily based on their assessed need. Their access is often determined by their age, which ministry their program belongs to, and any number of factors that have really little or nothing to do with their particular need. And we have 20% of our citizens have no drug coverage at all. So we'll be moving on that very quickly. And then finally, just to talk about research and innovation again. We have a unique opportunity now with Alberta Innovates Health Solutions as part of this ministry. We can have a fully integrated delivery system, and we can have research fully integrated with that delivery system, remembering, of course, our leadership role in discovery research as well. So that will give us the opportunity, I think, to bridge the gap. What I used to think of the gap was the difference between what we knew based on evidence and what we do in healthcare. And I think increasingly, and in keeping with the sustainability issue, the real question is, what is the difference between what we know based on evidence and what we actually pay for? And that involves a much more, I think, rigorous discussion, and it will be uncomfortable for some people about what some of the strategies are that we need to employ to eliminate that gap, because it is simply an opportunity cost that we can't afford in healthcare today. So I'm going to say just two more things before I finish. I'm often asked about the federal government, the role of the federal government, and people wondering exactly how the federal government perceives that. I do think it is an issue that we will continue to ask questions about, along with other provinces in the country. Certainly there's been a lot of discussion about the health accord, and of course we're not in a position now where we're going to have negotiations about the next health accord. We know what those funding levels are going to be. But we have many areas in the country that really lend themselves to national collaboration, where I think we have failed to meet the challenge. Two of those, one is certainly, I think, an obvious one to most people, and that's the area of drug coverage for Canadians. We tend to forget, I think, that our system was founded really on the principles of insurance. The foundation of Medicare was the notion that no Canadian should suffer undue financial hardship as a result of illness or injury. And even if you think about issues like personal responsibility, when Medicare was founded, there was an assumption that citizens would take an active role in mitigating their own health risk. And when you look back through history, you can see examples in Alberta. There was a time in our province, in 1935, for example, we had the first Health Insurance Act in Canada, where municipalities actually decided what the programs and services were going to be, healthcare programs and services that would be provided in their community. But when it comes to drug coverage in the country, I think we've failed to sort of consider the power of pooling our risk, our population health risk, and our financial resources in order to deliver better coverage for Canadians. So I'm certainly pushing that at the federal level. Some of my other colleagues are as well. And the second is, is the question of going back to continuing care, and how are we going to provide for all of those needs into the future. We pride ourselves in Alberta, rightly so, in having the most aggressive infrastructure program when it comes to continuing care. We open about 1,000 continuing care spaces a year. More and more of those spaces are built to a construction standard that allows us to deliver all levels of care under one roof, so we can allow people to age in place. But increasingly, we're going to face larger numbers in our population of people who need to access both facility-based care and home care, and increasingly end-of-life care. So I, along with some colleagues, are also trying to start a discussion on this at the national level. There are countries in the world that have publicly administered continuing care insurance, for example. So there are places where citizens at the age of 18 or 21 begin saving into a government-sponsored program to provide for their needs should they require continuing care in the future. In the countries like Japan where this exists, there are lots of options for people when they need continuing care. There's lots of choice. There's opportunities for their premiums to be returned to them if they're lucky enough not to need any of those services. But I think there are some serious questions that we need to ask ourselves as a province, but more notably as a country, about how we provide for these needs in the future. And is continuing care insurance something that Canada should consider when you look at the sustainability issue and when you look at the numbers of people who are going to require care? So those sorts of discussions, I think, are the ones that can be most productive at a federal level. So the last thing I'm going to say is something that's more of an abstract concept. I talked about some of the strategies to deal with the sustainability issue. I reflected on some of our successes and the challenges. What is the glue that holds all of this together? And I would suggest to you, ladies and gentlemen, that glue is relationships. The relationships between the leaders in the system that are here today, the relationships between government and the citizens that they serve, and most importantly, the relationship between providers and patients. We have all witnessed or participated in professional or regional turf wars in the health system. We have all experienced debates, academic arguments, and discord over certain issues and policies. This experience is not exclusive to the health system, nor to any single profession or player within it. But fundamentally, the complexity and the independence of the health system requires us to be highly collaborative in order to achieve the results that we want. And the health system of the 21st century requires us to plan and to act together in ways that will move us from discord to shared purpose. So I've talked about the recent physicians agreement as a case in point. I think in that agreement we found not only some stability in terms of compensation issues related to physicians, but we have within that agreement some initiatives that will see Alberta Health Services and the government and other partners working together to find efficiencies in clinical practices and technologies, to put the right compensation models in place that I talked about earlier, and most importantly to serve as a commitment to perseverance through adaptation and change that I talked about earlier. We'll soon be launching the next phase of the Family Care Clinic program, which will be part of our broader primary care strategy. This will allow local community engagement in targeted areas of the province to design their own programs to address their local community needs. So again, that relationship back at the community level, it's what's going to power the Family Care Clinic program. And so going forward, we need to coalesce around a more positive culture of change in health, incremental, purposeful, evidence-based, and collaborative. So in conclusion, I want to thank you for having me today. Nothing that I have said is intended to reflect in any way negatively on the tremendous bounty that we enjoy as a province when it comes to healthcare. But there is a call to action in here. And I think it involves a number of things. Taking deliberate and targeted steps to bend the cost curve in health spending. And I talked about the role of primary health care as being key to that. So a willingness and some perseverance on our part to think not only of the needs in the areas of institutions and providers and more money for the system, but to really think seriously about how well we're serving and how, in terms of the methodology, we're serving families and communities. Working purposely using the triple aim framework that I talked about to make the changes in the system that will improve outcomes. So for each and every initiative, asking how does that initiative in a meaningful way contribute to better care, to better outcomes, and to better value for taxpayer dollars. And then thirdly, as I've continued to talk about, and I will continue to talk about, positioning primary health care and a health home for Albertans as the hub of our system. As a testament to our commitment to a people-focused delivery system for Albertans today and for the generations that will follow us. Now, obviously, we can't do this alone. We all have to recognize the role that we can play, whether we're a patient with a chronic illness or perhaps on the cusp of a chronic illness, a mother who's expecting a first child, a health provider, a teacher, a union leader, a support worker, or even a politician. I've been involved in health policy for a long time now, and this much I have learned, and I've told that to you earlier in the speech. There's no magic bullet. But the other thing I have learned is that change can be messy, and it is often messy. We are not the best healthcare system in the world today, but we can be. We have the makings of the best system in the world. I very much look forward to working with each and every one of you to achieve the goal. I thank you for your commitment and your leadership in this province, and I think the opportunities ahead are truly very, very exciting ones. I know we're up to it, and thank you for the huge role that you're playing within it. Thank you very much.